Hello, everyone, and welcome to today's webinar on policy options to advance maternal mental health during pregnancy. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. And for those who are not familiar with us, welcome. We are a nonpartisan organization dedicated to advancing knowledge and understanding of health policy issues for the health policy community. Today's briefing is brought to you in partnership with Health Affairs and generously supported by the California Healthcare Foundation, the Perinatal Fund, and the W.K. Kellogg Foundation. I'd like to remind everyone that you can join today's conversation on Twitter at the hashtag AllHealthLive and join our community at All Health Policy, as well as on Facebook and LinkedIn. We want you to be active participants, so please do get your questions ready. You'll have a little icon with a speech bubble. You can use that to ask your questions at any time during the broadcast, as well as any tech questions that you may have, and we will try to get to as many of your policy questions as we can during this webinar. Please be sure to check out our website, allhealthpolicy.org. You'll get background materials, speaker bios, a resource list, and an expert list, as well as a recording of today's briefing, which will be made available following the session. Policymakers have turned increased attention in recent years to maternal health, as well as to mental health, and more recently, the topic of mental health before, during, and after pregnancy is gaining increased bipartisan attention. So before we turn to our expert panel, it is my pleasure that two bipartisan legislators from the House and the Senate have offered brief recorded remarks to open our conversation. First, I'll introduce remarks from Congresswoman Lisa Blunt Rochester of Delaware, and we'll roll the video.
Good afternoon, everyone. I'm Congresswoman Lisa Blunt Rochester from Delaware, and it's my honor to address you today at the start of the Alliance for Health Policy's Perinatal Mental Health Briefing. To President and CEO Sarah Dash, the Board of Directors, the staff, thank you for all that you do each day to advance equitable health policy in our country and for your tireless efforts to improve our country's healthcare system and help Americans better understand health policy. I'd also like to recognize today's speakers. I'm sure all of you will get a lot of knowledge and resources, and so thank you for sharing that information, and a special thanks to all of you, the attendees, for taking the time to join. You will hear from a diverse group of experts about an issue of utmost importance: perinatal health and its relationship with perinatal mental health. And importantly, you'll also hear about how we can all work together to implement policy to prevent mental health issues during pregnancy, especially in the face of the COVID-19 pandemic. The pandemic has only exacerbated issues that were already present in our healthcare system, including the rise of Black maternal mortality rates and the need for better mental health resources for mothers. We know that mental health is critically important for the health and well-being of expectant birthing people and their children. Unfortunately, health disparities exist for Black mothers and other mothers of color. As a member of the Black Maternal Health Caucus, I introduced a bill called the Moms Matter Act, which would make critical investments in community-based programs that provide mental health and behavioral health treatments and support to moms with maternal mental health conditions or substance use disorders. I'm proud to say that this bill, which is the only mental health title of the broader Black Maternal Health Momnibus Act, was included in the Build Back Better Act, which I voted to pass in my committee last month. The act would make historic investments in the women of our nation. It would save moms' lives and end racial and ethnic maternal health disparities and advance birth equity across the United States. Specifically, the Build Back Better Act would provide $100 million for maternal mental health equity grant programs. It would also provide $175 million in funding for local entities to address social determinants of maternal health like housing, nutrition, and environmental conditions. Ultimately, we will save lives and improve the quality of life for our families. I look forward to working with my colleagues and each of you to promote solutions to protect moms. I hope you find today's briefing informative and inspiring. Stay safe and be well.
Thank you so much, Congresswoman Blunt Rochester. And next, I'm pleased to introduce our honorary co-chair for the Alliance, Senator and Dr. Bill Cassidy of Louisiana, for his opening remarks.
United States Senator and Dr. Bill Cassidy, glad to be with you today, even if it's virtual. As a doctor, a senator, improving health outcomes for moms and newborns, top priority. And as a husband and a father, it's personal. Louisiana has one of the highest rates of maternal mortality in the country. And it's not just physical health implications that come with that, but mental health implications as well. I worked in the Louisiana Charity Hospital for over 25 years. I know the need to improve mental and physical health outcomes for all mothers. Earlier this year, I introduced the Bipartisan Maternal Health Quality Improvement Act, authorizing new federal grant programs aimed at reducing maternal mortality. Fewer moms die, particularly in those communities at highest risk, those which are medically underserved. That bill supports training, resources, and doctors and nurses to better care for new moms and their babies. I also worked with Democrats to write the Connected Mom Act, which makes indicators of potential pregnancy complications like blood pressure, blood glucose, and pulse available on the expectant mom's cell phone. On top of this, I remain focused on improving access to mental health services for mothers and expectant mothers. To the doctors in the room, physician advocacy, especially in regards to healthcare policy like maternal mental health, critical. As we continue to respond to the pandemic, we need the medical community to tell us how the pandemic impacts maternal health. We need your help, your insight, your knowledge from the front lines of maternal care. The best ideas come from experience. Doctors know where the system works and where it does not. Engage with policymakers at the local, state, and federal levels with solutions to these issues. Thanks for your advocacy, for your service to our patients, to the profession of medicine, to our country. I look forward to working with you to advance women's health care.
Sorry, Sarah, you're on mute.
I double-clicked it. I apologize, folks. All right, we're back. So thank you again to Senator Cassidy and Congresswoman Blunt Rochester for your remarks and for your bipartisan interest in advancing maternal and perinatal mental health. Before we move forward, I want to address briefly the terminology that you'll hear in this program and set our intention. Today, you're going to hear a blend of terms like perinatal, maternal, and birthing person, as well as women, parents, partners, moms. Our focus for this, again, is on mental health before, during, and after pregnancy. And we want to recognize that not all families look the same and that pregnancy, birth, and postpartum experiences are extremely varied. It is our intention to be as inclusive as possible with this briefing. And so we, again, look forward to hearing from our diverse set of perspectives on the panel and to hearing your questions. And we're really glad to be bringing this programming to you today to share the latest evidence, understand the real life impact of perinatal mental health challenges, and outline emerging and maybe emergency policy considerations, as this really is a more nascent area of both research and policy action. To learn more, I would encourage you to check out the Health Affairs October issue, which is dedicated to this topic, as well as the Health Affairs podcast and the event that they held earlier this month in October, in order to really delve into the research and the evidence. And now, joining me today is a panel of wonderful and noteworthy experts. I'm joined by Ms. Joy Burkhart, who is founder and executive director of 2020 Mom, a nonprofit social change organization working to close gaps in maternal mental health care. She has an extensive background working in quality improvement and legislative compliance for a Fortune 50 health insurer, and has a passion for improving access, quality, and innovation in the healthcare delivery system. Next, I'm pleased to introduce Dr. Veronica Lisby, who is a board-certified obstetrician and gynecologist and associate professor at Ochsner Health in New Orleans, Louisiana. She serves as the senior site lead and section head of obstetrics and gynecology at Ochsner Kenner and is the director of quality for women's services for the Ochsner Health System. We are joined today also by Ms. Carrie Hanlon, who's project director at the National Academy for State Health Policy, where she analyzes state policies designed to improve population health and advance health and racial equity, particularly for pregnant or parenting individuals and young children. She leads research and provides technical assistance to states with a focus on Medicaid payment, care delivery, and performance measurement strategies. And so pleased to welcome Ms. Kay Matthews, who is the founder of the Shades of Blue project. Ms. Matthews graduated with a 2-year degree in early childhood development from North Harris College in Houston, Texas, and furthered her education in the mental health field by becoming a licensed community health worker. She has received numerous awards from both her community and her peers, sits on the board, and is partners with several national organizations. Ms. Matthews has published best-selling self-help journals, 365 Days to Recovery, Finding Your Way Out of the Darkness, and the Recovery State of Mind Daily Journal. She teaches her community how to advocate for themselves before, during, and after childbirth. So welcome all, and let me ask Joy Burkhart to start us off, if you want to turn on your camera. Hello, hello.
Great.
Thank you for joining us, Joy. So I am going to turn it over to you to share your experience and characterize the current state of perinatal mental health here in the United States.
Great. Thank you so much, Sarah. And I first want to thank, on behalf of all the speakers, the Alliance, Health Affairs, the funders of all of this important work, and of course, the members of Congress who've taken leadership positions on maternal mental health, recognizing that this is a bipartisan issue that we should all care about. I wanted to start by sharing that though we're here to talk about a daunting problem that has largely been unaddressed, it's a very exciting moment for the field of maternal mental health. Thousands of cross-sector researchers, clinicians, and advocates have been working for years to get to this point, which is a tipping point in both awareness and identification of true and tangible policy solutions. As mentioned, my name is Joy Burkhart, and I serve as executive director of a nonprofit organization called 2020 Mom. We're a 10-year-old organization that has been studying the barriers to screening, diagnosis, and treatment of these disorders and identifying solutions that can be implemented at scale. I wish to acknowledge, and perhaps it should go without saying, that all women and families should have access to healthcare coverage, paid leave, especially after birth, and have their basic needs met. And this infrastructure should, of course, be available without unfair racial or even gender identification bias. My comments today, though, will focus on opportunities to improve the detection and access to care of maternal mental health disorders within the healthcare system. Because the US largely operates in a privatized health system, we all know that it can be very difficult to implement standards of care and track national trends. Several years ago, because of the great work of reporters, our national maternal mortality crisis was exposed. These reporters highlighted the critical role of the CDC and its partners, who were trying their best to support states in tracking these deaths with little funding and support. This reporting helped lead to the introduction and the passage of the Preventing Maternal Deaths Act, signed into law in 2018. It created a framework for the CDC to support states in investigating causes of maternal deaths, setting in place a strong movement, which so many of us are thrilled to be a part of, towards improving maternal health and maternal health care delivery. That work didn't initially include and has only just begun to scratch the surface in maternal deaths by suicide or even overdose. Why is that? It's in part because we're talking about two systems of care, not just the medical care system, but also the mental health care system. And this is why the policy implications for maternal mental health care must be addressed both within the context of maternal health and on its own, and in the context of mental health. So I wanted to start with some more basics. You might be asking, exactly what do you mean by maternal or perinatal mental health disorders? What are they? And most of us, I think all of us, have heard about postpartum depression, which is where research first centered, right? And which for 10 plus years, postpartum depression has been declared the most common complication of pregnancy. But there are many more disorders and symptoms that are equally as important to identify and treat with accuracy, like maternal OCD and intrusive and unwanted thoughts, like mania and psychosis, birth trauma and PTSD, and anxiety, which we now know is more common than even depression during the perinatal period. And we define the perinatal period currently as pregnancy through 1 year postpartum. So there's a range of disorders and a range of onset. And so we know about postpartum depression and now the other disorders. And we're also grateful that society has started to talk about and begin to understand the negative impact of these untreated disorders, not only on the mother, but on the infant and early childhood brain and central nervous system development. But what about pregnancy again? Not just the postpartum? Research is clear that new onset of depression and anxiety is nearly as common in pregnancy as in the postpartum period. And when untreated in pregnancy, these disorders can impact the baby in utero and lead to preterm birth. We also know that even prior to the pandemic, tween and teen girls and young women in the US were suffering from their own mental health epidemic. And many of these young women are now having babies with pre-existing and often untreated mental health disorders. Perhaps they were stable on medication and were being treated, but directed to go off medications by obstetricians who include OBGYNs, midwives, or even family practice providers who treat during pregnancy and deliver babies, but without either of the provider or the patient fully understanding the pros and cons of going off medication. As a nation, we're now also tuned into the growing mental health problem in our country, which has now, because of COVID-19, become so pervasive, not just in young girls, but in all of the population, that 1 in 4 Americans are suffering from mental illnesses right now, and mothers certainly have not been immune. So with all this in mind, you might be asking, okay, I get it. What do doctors think about maternal mental health disorders and what their role should be in solving this crisis? And what do professional trade associations like the American College of Obstetrics and Gynecology and the American Psychological and Psychiatric Associations have to say? Well, they all agree that screening and identification should be a top priority for healthcare providers. The American Academy of Pediatrics should be applauded, as they were the first trade association to recommend screening, recognizing the critical impact on infants, not just mothers. It wasn't until 2015 when the American College of Obstetrics and Gynecology first recommended screening that things really began to change for the field. Their recommendation triggered a chain reaction, and most notably, the US Preventive Services Task Force, convened by AHRQ, a federal agency, recommended screening in early 2016. Because of their recommendations, carrying a requirement that insurers cover such services, there was excitement, and there was also misunderstanding that suddenly screening would just happen, now that the US Preventive Services Task Force has said it should be so. The core problem, though, was not insurance denials of screenings. Screening was really already largely being covered by most insurers. Rather, it was and remains that substantial barriers for both providers and patients exist in referrals and access to mental health care. But why is it so much harder to access mental health care over medical care in the US? Well, we believe that there are three main reasons, which I like to refer to as the 3 Ps. And I'll go over those very briefly. First is payment. In the US, we have a separate payment system for mental health care, as I've addressed, a separate delivery system. And this exists for both privately insured and publicly insured patients. It's what we call, and you've heard be called carve-outs, mental health carve-outs. And until carve-outs are addressed, we in the maternal mental health field will hobble along, trying our best to adequately detect and treat maternal mental health disorders and other mental health disorders until mental health payment is reformed and carved into the medical care system. Providers. Education of providers, shortages of providers, capacity of providers, including care coordination, access to expert consultation around mental health, and incentives in payment. And with providers and this P, we can start by supporting reimbursement of obstetric providers for screening and initial treatment plan development. We can also provide grants to states and public health hospitals to develop inpatient and outpatient treatment programs and look to SAMHSA. So there's a continuum of care. SAMHSA has developed residential treatment programs for substance use disorders, which we think can be replicated for mental health disorders. And again, there's an opportunity to create a continuum of care for maternal mental health disorders, not just an hour of talk therapy with a behavioral health professional or the ER, which is essentially what exists right now. We also must quickly address mental health provider shortages. And one way we think we can do this quickly is to proliferate the use of state certified peer support specialists, which can be referred to as a form of community health workers that treat mental health disorders or support mental health disorders. Every state now has a state-sanctioned certification process in place for peers. These peers can not only provide mental health support, but can be trained to screen and also provide clinical and social support care coordination. And finally, the third P, performance measurement. In a fragmented, privatized health system, a framework for quality measurement is absolutely critical and helps to implement a standard of care and hold payers and other players accountable. We don't yet have a measure in place for screening rates of maternal mental health disorders or for measuring outcomes when patients are screened. Are they getting well? Those measures don't yet exist and are critical to solving this problem. These 3 Ps, payment, providers, and performance measurement, offer immediate and tangible next steps for policy and healthcare systems change. And I can't wait to unpack these with the others on the panel. And I now turn it back to my colleagues Sarah Dash and Kay Matthews from the Shades of Blue Project.
Great. Thank you so much, Joy. I mean, you covered a really extraordinary range of issues from, as you said, the 3 Ps, payment, provider, performance measurement, the history of screenings. I don't think I had realized it was quite so recent within just the last 10 years. So with that, and just in the interest of time, I'm going to go ahead and turn this right over to Dr. Veronica Lisby Bell, who can tell us more from that provider perspective what she is seeing on the provider level. And Dr. Lisby Bell, thank you for joining us today and on call on top of it. So
yes,
thank you for carving time out.
Of course, my pleasure. Thank you so much, Sarah, for that introduction. And thank you all for allowing me to be here with you today. Thank you to the Alliance for giving us a platform to be able to convey our experiences and our suggestions and opinions. And thank you all to the members that are here to hear what we have to say about mental health disorders. Today, I will give you my perspective as an obstetrician and gynecologist practicing here in Louisiana, but I will also give you my perspective as the medical director of the Louisiana Perinatal Quality Collaborative and the Pregnancy Associated Mortality Review. As the medical director of the Pregnancy-Associated Mortality Review, I lead the committee that reviews all maternal deaths in Louisiana, regardless of cause. We define a death as the death of an individual during pregnancy, up to 1 year at the end of pregnancy, regardless of the cause. We just released our 2018 Pregnancy-Associated Mortality Review Report. And in that report, we revealed that the leading cause of maternal death in Louisiana in 2018 was substance use disorder. And we know that a lot of individuals that are using substances are using them to self-medicate for mental health disorders. And so we know that we have to address mental health disorders if we're going to improve substance use disorders and thusly improve our maternal morbidity and our maternal mortality. The other thing that we noted in doing this review is that looking at the time frame from when the majority of those deaths occur, 83% were after 42 days. And I say that to say that we traditionally think about pregnancy and pregnancy care as pregnancy and then 6 weeks after. And so as we think about policy changes and the things that we will need to address so that we can improve mental health disorders, it will be also addressing how we think about the postpartum period. That is not just a 6-week time frame. We have to think about destigmatizing mental health. And so the discussions that we're having today are opening up further discussions around our communities and our country so that we can destigmatize mental health. In certain communities, especially communities of color, and especially because of historically, particularly Black women, how we have been portrayed and conveyed in social situations and having to be portrayed as such strong Black women that are just continue on. It is stigmatized to sometimes mention or say that you need help. And so we have to destigmatize mental health by continuing to talk about it and to normalize the fact that mental health and perinatal mood disorders do happen, as my colleague mentioned just a second ago. As I mentioned, when we look at these maternal deaths, 83% of those pregnancy associated but not related to a condition of the pregnancy occur after 42 days. So that means that we need to make sure that our pregnant birthing persons have access to care. That means expanding Medicaid beyond 6 weeks up to 1 year postpartum. And I know that Medicaid is a state decision as far as expansion is concerned, but I do think that there's congressional things that can be done to help encourage states and incentivize states even more to expand Medicaid. Having access to care is something that helps to improve these maternal outcomes, as we know. We also have to think about the social determinants of health, as was mentioned previously. We know that those social determinants of health, transportation, housing, all those things are barriers to care. Because of those social determinants of health, we have to think about different ways of delivering care. I commonly have said we have built a healthcare system around the healthcare system and not a healthcare system around our patients. We make it very difficult for patients to see us. And in 2021, we have to think about using things like telehealth as a way to deliver care in a different way. As Senator Cassidy mentioned, he introduced the Connected Mom Act, and part of that was work that was done with myself and partners here at Ochsner. We have a Connected Mom program where we are able to offer telehealth for our patients, to be able to set up virtual visits. I actually have a few coming up this afternoon. And so it allows patients to be in their environment, be in their community, and still be able to connect with the doctor. In addition to telehealth, we have to, not that it is the end all be all, we have to also improve the infrastructure to be able to have telehealth. We know that in rural areas of the country and in urban areas, broadband is not what it needs to be in order to achieve some of these means of telehealth that we want to use to help connect with our patients better. So in addition to the having telehealth as in our electronic medical record and in our healthcare systems, we have to build up our infrastructure so that our patients can access the telehealth. And again, thinking about different ways of delivering care, community health workers, they are so important to improving maternal morbidity and mortality from a lot of different causes, but especially when we talk about mental health and perinatal mood disorders. It's so important to be able to go and visit a patient in their home and understand what their environment is like, what their social determinant of health looks like, to better be able to treat them. And through the use of nurse home visiting programs, through our community partners, through doulas, through perinatal health workers, we have the opportunity to expand our obstetric workforce and actually bring care to the patients and visit those patients in their home. Also thinking about legislative policy and things that can help improve our outcomes from mental health disorders, our state perinatal quality collaboratives. As I've mentioned, I am the medical director of our Louisiana Perinatal Quality Collaborative, and I am here to tell you that quality collaboratives can lead to change. The change that we have seen in Louisiana is not unique, but just to mention how we have the ability to change, our initial initiative was reducing maternal morbidity from hemorrhage and hypertension. And by working with our birthing facilities to use improvement science to help put those best practices into place in birthing facilities, we were able to reduce severe maternal morbidity from hemorrhage by 35% and by 49% for Black women, and then reduce severe maternal morbidity from hypertension by 12%. So we know that our state perinatal quality collaboratives have that ability to change. And now, one, we need to make sure that there is a quality collaborative in every state, that they have funding to exist. And then those quality collaboratives need to lead those initiatives to help with screening and treatment for substance use disorder and perinatal mood disorders. As it was already mentioned, we don't have accountability around screening. It is the recommendation that we screen at different intervals for postpartum depression, which is only one mood disorder. That recommendation is in there, and so that is a best practice. But when we have best practices and you don't use improvement science to put those practices into place, it can take 17 years. And so it's not that we don't always know what to do, we don't know how to do it as providers and as healthcare systems. And perinatal quality collaborators are really good with the how do you do this. And so again, we need to use our state perinatal quality collaboratives to make sure that every birthing facility, every provider's office is doing what we call SBIRT, screening, brief intervention, and then referral to treatment. And as we think about referral to treatment, that means we also have to expand our obstetric workforce, and not in the way that we may think of obstetricians and doulas and midwives, although we do need to expand in that way, but we need psychiatrists and we need to have access to psychiatrists. We do a social determinants of health dashboard here in Louisiana as we review our maternal death. And if you look at our dashboard, we have more mental health providers in Louisiana than per capita than most of the United States. However, that does not always equal access. Many of those providers do not accept insurance, and they definitely do not accept Medicaid for an insurance. And so we need to think about ways to incentivize improving and increasing the number of psychiatrists that will be specifically dedicated to perinatal mood disorders, but also that will then accept Medicaid and help the underserved and the underserved. We have many policies and many different programs to improve the number of primary care physicians in rural areas, which is great. And psychiatrists are typically not seen as a primary care physician, but I believe that they are primarily, and they have a huge important role to play in making sure that we are improving our maternal outcomes and for being able to screen and treat for perinatal mood disorders, as well as substance use disorders. As it was already mentioned, one of the barriers to screening is the inability to then refer patients, and where do you send them and how do you get help? And I saw this firsthand. I've seen it many times firsthand in my practice, but I think the time that stands out the most for me is a patient that I was taking care of. I had taken care of her for her whole pregnancy. from the time she was about 12 weeks. Was very excited about the pregnancy, had good family support because I took care of her family members as well. And everything had been going great. And then at 32 weeks, she came in and she said, I need it to stop moving. And she meant her baby. And she very well knew it was not a it. She knew the gender of the baby. And she said, I just need it to stop moving. I keep hitting my belly because I need it to stop moving. I am hearing lions and seeing snakes and bears. And, we talked through that. And immediately I said, well, we need to get you into the emergency room because you are having, you seem to be having some homicidal, suicidal ideation as well as psychosis. We got her to the emergency room. And because she did not say the right words, then she could not be what we call PEC'd, where she is made to stay in the hospital for suicide precautions. And so she was discharged home. And so I worked with her to try to find a psychiatrist that could treat her and could treat what was starting to become psychosis. And she did have Medicaid as insurance. And by the time when I could find a provider, the earliest that they were able to see her was 3 months. And though I am not a psychiatrist, I am trained. It is part of our training as obstetricians to at least begin that screening, brief intervention for treating a range of perinatal mood disorders. And so I was able to start treatment, and she was able to get stabilized and was eventually able to see a psychiatrist. But it was just a lesson to me, and I'm just one provider, and this was just one patient, of how difficult it is to access mental health services. Even when you have insurance, it's still under insurance, and it makes it very difficult. I'm thankful that the patient felt comfortable to talk to me and that I asked the right questions and we were able to start treatment, because I am fearful to think of what that outcome would have been had we not been able to partner in her treatment. And so I have plenty more to say, but I do not want to monopolize all of the time. So I'm going to stop right there and turn it back over to Sarah so we can hear from our other panelists.
Thank you so much, Veronica. What a dramatic story, and just illustrates. I mean, if it's that hard to find care for somebody in such dire distress, and really life-threatening distress, the so many women and birthing persons who are experiencing perhaps less acute, but also, depression, anxiety, things that really interfere with their functioning, and how hard it is to then, find care for that. So, I know we'll get into some more of those workforce and access issues, but I think that certainly illustrates some of the challenges. So thank you. And so next, I'd like to turn it over to Carrie from NASHB to go ahead and share what is happening at the state level, and then we'll hear from Kay Matthews, who is going to share our community perspective. So Carrie Hanlon, go ahead. And by the way, just for those who are used to a 1-hour webinar at the Alliance, this does go to 1:15. So I just want to point that out to you all, 1:15 Eastern time. So please go ahead and also submit your questions while you're thinking of them. All right, Carrie, over to you.
Great, thank you so much, Sarah and the Alliance, for providing the opportunity for my organization and me. I'm with the National Academy for State Health Policy to participate. I learn something new every time. I attend one of the webinars and hear from these panelists. It's great, rich information. As was mentioned, my focus is on state policy and particularly Medicaid policy. That is what the organization I work with, NASHB, focuses on. So I wanted to highlight some of the trends that we're seeing in terms of how states are working to promote access to high quality perinatal mental health care within Medicaid programs specifically. And so touching on some things that have already been mentioned, but maybe adding a little bit more detail. So I'll mention coverage. So of course, our perinatal mental health services offered in a state's Medicaid benefit package, how long are those services covered for, and then also look at some ways that have already been mentioned that other providers and practice settings can be included and are being included in efforts to help identify mental health needs. And then finally, again, piggybacking on some of what's been mentioned, talk about some of state efforts to measure and reward efforts to identify and improve identification of perinatal mental health needs. So I just want to start by looking at coverage. So federal law requires pregnancy-related Medicaid coverage to last through 60 days postpartum, but states we see are increasingly looking to extend that coverage for all of the reasons that have been mentioned, to ensure that postpartum health and mental health needs are met, to promote continuity of care, and to reduce maternal mortality and morbidity. And I just wanted to highlight some recent examples. So Georgia provides postpartum coverage for 6 months. Missouri received approval to provide substance use disorder and mental health services for those individuals diagnosed with a substance use disorder for up to 12 months postpartum. And then just yesterday, New Jersey received approval to extend postpartum coverage to 12 months. And so the program is a partnership between the state and the federal government, but just wanted to note that that is definitely a trend and that there is growing interest in that. In terms of who provides care and can help with mental health needs during pregnancy or postpartum, again, there's growing interest in exploring opportunities to invest in non-traditional providers, including, for example, doulas, to support pregnant and parenting people. And there are at least 3 states that are authorized to offer a doula benefit in their Medicaid programs, and several more that are in various stages of implementing that coverage, because current evidence suggests that pregnant people who receive doula care are more likely to have a healthy birthing outcome, which can lead to cost savings for state Medicaid programs and improve overall health. And I think, as has been mentioned before, doulas provide continuous physical, emotional, and informational support before, during, and after birth, and promote health equity, and can help address some of the social determinants of health that have been mentioned. And I wanted to note that there's a particular focus in states on community-based doulas who are trusted members of the community who collaborate closely with community stakeholders and institutions. And so that's definitely an area that states are focusing on within their Medicaid programs. And then, as has been mentioned, another provider who can help identify particularly postpartum mental health needs are pediatricians or family docs who provide the well baby or well child checkups, as I think Joy mentioned. And it's something that states overwhelmingly have policies about. So most 43 states have a policy around reimbursing and covering postpartum depression screening during a well visit for the reasons that have been mentioned. Just the understanding that maternal or primary caregiver health is intrinsically linked to young children's development. And I just wanted to kind of try to pull it all together a little bit by noting that Medicaid agencies also promote access, or aim to promote access to high quality perinatal mental health care by requiring providers or the managed care organizations, if they have that type of system, the organizations that they contract with to deliver services, to measure and improve performance in areas of care like screening for substance use or depression among pregnant people, or by offering providers or contractors rewards for meeting quality goals in those areas. And this is something that NASHB's looked at across the country. So one example is quality measures, which have been discussed, that there are some gaps in terms of availability there, but this is an area where state Medicaid agencies can require providers or managed care organizations to report, or these are things that managed care organizations may track voluntarily. The state can also require managed care organizations to undertake projects to improve aspects of care. That topic can be picked by the state or by the contractor. And here again is an area where there has been emphasis on things like improving linkage to addiction services during pregnancy, and other aspects of perinatal mental health. And then the payment is always so important, and looking at how to reward improvements in access to care, and how to reward delivery of care in innovative ways is something that there's a lot of state activity in. And I just wanted to mention one that I think is an example of pulling together the quality measurement, but also the care delivery, who's delivering the care. So Pennsylvania is an example, just one of many states that has a particular payment initiative around maternity care where providers can earn incentive payments for meeting goals in measures around social determinants, as well as prenatal and postpartum depression screening and the follow-up, and then initiation of substance misuse or dependence treatment. And a key part of the initiative is a maternity care team that includes both licensed and non-licensed staff. And the unlicensed staff can include community health workers or doulas. So just a few options and examples of ways that state Medicaid agencies are working to promote access to high quality perinatal mental health care. And just want to underscore what has been mentioned before, just the importance of partnership between Medicaid and other improvement collaboratives, other agencies in the state to make sure that, for example, Medicaid related recommendations or suggestions have are implemented and can be put forward to help improve outcomes in states. So thank you, and I'm looking forward to further discussion.
Great, thank you so much, Carrie. This is great. And so it is now my pleasure to introduce Kay Matthews, and we've heard so much about the importance of community organizations and community providers. And so I can't wait to hear your story, and you're also an author in the health affairs issue. So welcome to the panel, and turn it over to you.
Thank you, Sarah, and thank you for having myself and the Shades of Blue Project as a part of this panel. I'll jump right into how important it is to have community components in all that is being done. What you've heard from my colleagues is about the current policies that have been enacted state to state, how each state is certainly different. I'm in Texas. We somewhat always think up our own rules here, so we know how that works. But the community piece becomes so very important in many ways in thinking about how community level care can be a tad bit different from the medical care system. There's a level of trust that is built within those of us that are working in the community. But how we play a part in the healthcare system is we merge our ability to be able to serve the community in a way that we can then carry that over to where our clients, who would be the healthcare's patients, we can work collaboratively and collectively together. One of the things Joy touched on was the peer support model. That's very, very effective. We so often in mental health, just as a whole, and we specifically are talking about maternal health, we want to know that someone is feeling like us, like we're not by ourselves, we're not alone. Others know that we exist and that they may be experiencing the same thing. And that's really how the wheels start to turn with getting help, is someone who can have a conversation with you, just like, and y'all can identify together and then go from there. And then the care coordination starts to happen there. So the peer support model is very, very important in all of this. And how the peer support model can continue to grow is definitely through policy. Policy has to back this model wholeheartedly across the board. And we're starting to see that, of course, in the Moms Matter Act and in several ways, but the value has to be there. The value to know that we can work with doctors, nurses, hospitals, clinics, and bridge that gap that currently exists. When we're thinking from a population standpoint of African American women are less likely to receive any type of assistance when it comes to maternal mental health, whether that's a diagnosis or an acknowledgement that something is actually happening. That's rare. Our numbers are 1 in 4 versus 1 in 7 will experience a perinatal or maternal mental health mood disorder. So those numbers are disparaging alone, right? So we know what solutions can actually work. And to be honest with you, this is a collaborative effort. We've all got to come together in this way. Policy is one piece. Like policy is the overarching piece that tells us that, hey, this is how things are supposed to go. And then everything up under that policy starts to fall into place. And this is how we're going to reduce these numbers across the board, reduce numbers on the mortality and morbidity side, reduce numbers in mental health. All of these things fall under. I always say that the mental health component is also at the top, and everything that happens under it. But so often mental health is not at the first and foremost of our minds. We're trying to address all of the other things, but not. So in other words, we typically are right now addressing what has been done or what adverse outcome has happened to the woman or the birthing person versus how this person feels about what has happened to them. And so when we merge those two things together, that's our power right there. That's how we decrease stigma. This is how we decrease our numbers. We turn this whole thing around. And then also when policy backs us, like what is out there, what is happening right now in policy, which is great, because I know some folks that have been working in this field for 20 plus years, and now they're starting to see how it's all turning around and it's getting better, but we still have so much further to go. One of the things also is what policy is doing and bringing in this peer support model is us being able to acknowledge that all birthing experiences are encompassed in that. We have to acknowledge that a birthing experience and the outcome is not the same. And so we have to acknowledge that as well. But pulling in the community, that's going to be the key component to this. We cannot do any of this without the input from the folks that we are actually out here fighting for with the policy. We're making policy for people. Now we need to involve the people in the implementation of the policy. I'm actually looking forward to more of the Q&A piece because the conversation is what we need to have at this point as to those that are on here right now. How can we take what we've learned today from myself and others that are on the panelists and start to implement it like right now, right? And then when policy kicks in, we're ready to rev it up and go, because this is an action step that certainly has to happen.
Thank you so much, Kay Matthews, and I'd like to invite everybody to join us. And while they're doing that, you said something that I thought was so powerful. You said it's not just what happened clinically or what the outcome showed maybe on a piece of paper. It's how the birthing person felt about the experience and how they're feeling. And the question I want to start off and ask each of you is, are we asking the right questions, and are we asking the right people and communities? And if we're not, what do we need to do about that? And how does policy and how do policymakers need to support that? And I suspect that has something to do with the quality metrics and the performance measurement. But let me start with you, Kay, since you kind of rounded out. I mean, are you seeing that the right questions and the right people are being asked now about, these perinatal mental health challenges, or how far do you think we have to go?
We have a long way to go. It's about responsibility. You have to be committed to doing this. When we talk about screening, it's great to screen, and then what? You have to screen and refer, and not blindly refer. So see, there are many steps in doing this the right way so that folks are receiving the care that they need. You screen, right? Mom tells you I've had my clients come in and say, well, I actually circled this on the PHQ-9 or the Edinburgh, and nobody said anything to me. They just took the paper and added it to my stack of files. So see, that's not the way to screen. When we have a responsibility to screen, we then don't blindly refer. So when we refer, we also have to make sure we're referring our clients or patients to someone who is going to help them. There's no need to take them from one place to the next, and then they feel like, you know what, this is just not working. I'll just figure it out. And so many people have the mindset, I'll just figure it out, because the system is not working for them. And so we have a long way to go in our accountability of who should actually be doing the screening. And then when you are doing the screening, your referral process, and then the follow through. It takes absolutely nothing to follow up and say, hey, I referred a patient over to you 2 weeks ago. How's everything going? So referring, following up is very imperative to making sure that folks are really getting the care and the help that they need.
Thank you. And Veronica, you had pointed out you didn't really sound like the systems are in place clinically, or they're maybe starting to be put in place. And I'm curious, because I had heard something in the Health Affairs podcast that, as Jennifer Moore pointed out, who was the issue advisor for that a lot of these screening tools were actually developed on, white women with commercial insurance predominantly. So do you have thoughts on that? Like, how could the actual quality of the screening tools themselves be improved?
Yeah, I think that's a really good point. I think part of it, and I'm going to say this as a provider, the screening tool is just that. It's a screening tool. It's not a diagnostic tool, and it is the place to open the conversation. So just as Kay was mentioning, if we're going to give patients a piece of paper or send out something through the electronic health record, or have them do it when they come to the office, where they fill it out and then it goes into their file and nobody ever looks at it, then that's not helpful at all. It is meant to be a way to say, I'm looking at this, and I'm one provider, this is what I do in my practice, but I look at the score and say, looking at this, and I ask every single patient, no matter what their score is, I looked at your scale and your Edinburgh postnatal depression scale, your score is this indicates this. Do you agree with that? Is that how you are feeling? And it's just so important to start having that conversation. I've talked to patients where they are depressed, they need medication, they need to be in therapy, because we know that outcomes are better if you can get into psychotherapy and pharmacotherapy. I've talked to patients where it's not about needing medication, it's about the adjustment of being a new mom. And I can't really prescribe this. My prescription is, you need some help. You need some family help. This is how you can, these are some resources to get somebody to help with food, to help with to help with a nanny, to help get childcare for your other children, to overcome some of those other life stressors that are making it harder to adjust. And so again, the tool is meant to start the conversation, not to be the diagnostic tool.
Thank you so much. And I want to ask Joy if you have thoughts on that. And I love that if you could just write, your prescription is you need some help. Like, what can the system do to actually address that? And then Carrie, I want to ask you specifically in the Medicaid, and get more specific on how Medicaid and states can address some of these things. So Joy, any thoughts to add on this?
Yeah, a couple thoughts come to mind. And I love that first comment that, just prescribing, get outside, get some sunshine, take your vitamin D and your omega-3s, which are evidence-based here too, matter. And those are simple action steps all providers can take. But where I really sit here is that until we integrate payment systems and reimburse OBGYNs, other obstetric providers like midwives, and even family practice providers in rural settings, these things are hard to do. And not all providers have received some of the baseline training that we heard about in mental health. Many obstetricians, especially those who've been schooled long ago, still haven't had baseline training in mental health. And so how do we look at solving those gaps? Those are things I think we should look at critically. But in terms of who we're screening and how we're screening, there's definitely some opportunities there. I always love Kay's remarks about not leaving people out and doing this in a culturally responsive way. And of course, addressing the then what, not putting the screener in a tool. And we really point back to the role of obstetric providers and the then what. There should be no wrong door, but obstetricians really can develop the treatment plan. I love the expert model too. Dr. Jalipsy Bell, in mentioning that model as a framework for mental health.
Great. Yeah, and on the note of not leaving anybody out, we have an audience question about making sure that, the Hispanic population is also not left out, that PPD is higher, and wanting to know if anyone here is addressing that. And I might give Carrie the very difficult task of saying, as you're looking at, starting from this point of, are we asking the right people, the right questions at the right time, you know, and then what can state Medicaid agencies in particular, and then other aspects of state policy do about this? Like, do we even have the right tools to figure out, you know, who the populations are that we're trying to reach, and how, and then how do we bring some of these best practices forward at the state level?
Yeah, all great questions. I mean, I think as far as do states have the information they need, I think it's better. I feel like the states we work with, they always want it to be even more better. I mean, certainly limitations in terms of missing race, ethnicity, language data is a challenge, you know, reference earlier to siloed systems. And, you know, kind of facilitating this no wrong door approach, if a potential need is identified in, you know, one care setting, how does a provider in a different setting find out about it? And, you know, some of what Kay mentioned before about what happens to a referral, how to make sure that every provider involved in a person's care has the information they need. I mean, these are huge and expensive questions that, you know, I think do kind of go back to, you know, the core question, Sarah, about are the right questions being asked, is who needs to give input being considered. And I think that, you know, in terms of how to make sure the information sharing gets done in a way that is meaningful and most, you know, helpful to patients is, you know, I think that's the ultimate challenge, is how to make sure that that feedback is first solicited and then directly applied to policy. And I think that it is, you know, it's baby steps and kind of an ongoing challenge. But I think that is, states are looking to do that. How can we have consumer advisory panels? But again, it's this balance of making sure that community members aren't being overtasked, are being compensated for their time, and that they feel like they are being meaningfully engaged.
Mm-hmm. Thank you. And it's like you're reading the minds of our audience, because we got a really good question from someone who says, as a philanthropic organization, they're looking to build a better system to support maternal mental health and well-being. And as they engage partners, who really should they ensure is at the table? And they mentioned, you know, women and birthing people, OBGYNs, mental health, home visit, you know, who are we missing? And I'm sure we'd be happy to follow up, you know, here at the Alliance with a conversation about that. But it does point to, like, you know, let's all remember that new parents are also a little busy, and it's hard enough to participate. So, like, is there a constituency around these issues, right? Because once you sort of are no longer in that chair with a newborn baby, or you're busy with preschool and you're busy with everything else, and you know, that might be kind of an interesting, I think, Joy, maybe that's some of what you're trying to work on in K at the community level, is building that constituency. Yeah, it's hard to believe we only have 10 minutes left, so I want to kind of keep moving here with the conversation. I want to, again, just to focus on policy. And by the way, for those who are interested in the postpartum coverage provision or option, the Kaiser Family Foundation has a great state tracking tool, and we'll make sure that's in the resource list for you all. But Carrie, let me keep you on the spot for just a minute here. I mean, you mentioned that 3 states, I believe, have expanded coverage for doula services. And then I wasn't quite sure how many states had also expanded sort of requirements for Medicaid managed care, as far as, you know, other things that they could do. Can you get more specific? Like, how do you specifically expect that these policies would affect perinatal mental health, improve perinatal mental health? Like, what outcomes would you be looking for?
Yeah, that's a good question. I mean, and I think it goes back to that idea of having good quality measures. And I think that's why state policymakers and providers and community members are all feeling a little stuck. I mean, as far as, you know, so let me take a step back. So your question is, for states that have added a doula benefit, what would we expect to see as the outcome from that?
Yeah, let's start with that. That's a good specific question. Yeah.
Sure. So, I mean, I think one, and I would definitely defer to co-panelists as well. I mean, I think it would be some of the qualitative things like feeling listened to, heard, represented, you know, the importance of culturally congruent care. But I think also because of the benefits of culturally congruent care, that things like, you know, postpartum visit, timeliness, follow-up for screenings. I mean, I think it gets to more the quality measures we do have, seeing an increase in those. And there are states that do a lot of hotspotting and analysis of social determinant and other information across the state to see improvements in the areas where there is most need.
Great. There was a question, thank you. There was a question that came in around privacy rules, and I'll ask you, Dr. Lisby Bell, around, you know, do you think privacy rules get in the way of understanding a pregnant person's mental health history? How important is that in clinical care? Do you think, like, what can be done on that sort of information front, or are these things that just kind of arise in pregnancy, like you pointed out?
You know, in my opinion, privacy is not the issue. Our system is broken. That's, you know, as Kay mentioned, our system is broken. When I think about the maternal deaths that we review and we look for areas of prevention, I cannot tell you how many times patients were seen in the emergency room, seen in urgent care for substance use disorder, for IPV, for mental health disorders, and a referral was made, but nothing. That was it. The referral was made. There's nobody there to link the pieces to close the gap. To if I have a patient that is in, for example, the home visiting program, and the home visitor sees something or tells something, there's no way for that connection to take place. As Kay mentioned, and I mentioned as well, we've got to expand our obstetric workforce, and so we do need to use perinatal community workers. We need to use doulas, but we've got to connect those systems so that we're not working in these silos. I think privacy is very small, and we have ways of with HIPAA and those things that we can get around any privacy issues. It's just that we don't have anybody to connect the systems.
Yeah, thank you so much. And we did get a question about whether any of these policies address mental health needs of people who have lost a pregnancy and via a miscarriage or stillbirth. And while I'm going to say I think the answer is no, but I want to ask you as the clinician also, like, do you have, is there special care that's needed in those circumstances?
I would say in general, we don't have policies that specifically address the mental health need for patients that have experienced loss. I think we as clinicians do screen differently for those individuals and screen more intently for those individuals that have experienced a loss. From a policy standpoint, not exactly completely addressing the mental health disorders, but we did in Louisiana in our last 2021 legislative session, a bill was passed that gives income tax credit for any individual that experiences a stillbirth. The way that, and I know laws are different from state to state, but because there are burial expenses that are associated with that time period between 20 weeks and 24 weeks, where 24 weeks is really the cusp of viability. And if you deliver that pregnancy, then it has to be buried. And then there's in addition to the mental anguish that goes along with that, then there's a financial component too. And so that bill did pass to at least address that part of it. And so at least I think that is highlighting and putting an emphasis in our state on some of the specific challenges that individuals that deliver a baby that they don't go home with, that they experience.
Thank you so much. And obviously a very complex and challenging set of circumstances, but since that is often kind of stigmatized or swept under the rug, I thought that was an important question from our audience. So we are sadly almost at the end of our webinar for today, and there's so much more to talk about. So I thank you all for joining us. I want to ask each of you if you could just to give sort of a if you had your magic wand, if you could wave your magic wand and make one change today, what would that be? And let me start, Kay, if I may begin with you. If you could wave your magic wand, what change would you ask for?
It would actually be a follow-up to what Dr. Bell just discussed, is that we don't look at infant loss as something separate from the maternal health experience. It is a birthing experience. And so when we think about mental health, we must think about all outcomes. So there's birthing experiences and outcomes, which all have this way of including maternal mental health. So that's my magic wand, is that we stop separating birthing outcomes and we look at whole birthing experiences.
Thank you. Joy, what would you do?
Quickly, I'm going to bring it back to policy and say that we need to, if I were to wave my magic wand, we need to pass the Moms Matter Act and also look at the Triumph Act. Moms Matter Act addresses gaps in care by Black and Brown women. And we know that those gaps exist in extraordinary ways and they have to be solved for. And the Triumph Act calls for a task force, a federal agency task force, to look at the roles of various federal agencies in solving this problem of maternal mental health, and also issuing a report back to Congress and to state governors and legislatures on the role that states can play. I would wave my magic wand and make those two bills pass and get signed into law.
Thank you. Carrie, your thoughts?
Mine is probably a little geeky, but it goes back to the information sharing and connecting the dots. I think everyone mentioned that, just kind of like flipping a switch so that everyone has, all different providers have access to information from, you know, different parts of the system, and also that people themselves have that information and can inform it and correct it where needed.
Thank you. All right, and finally, Dr. Lisby-Bell, you get the last word since you're on call.
Thank you. I think for me, and I do think this could be addressed with policy. I would have, for every individual that enters pregnancy, would enter pregnancy with a perinatal nurse navigator to help connect the dots, to help follow through, to help connect the obstetrician to the psychiatrist, to the cardiologist, to be that medical home, that one person that is in that patient's medical home to connect the dots. It is very difficult as a layperson to navigate the health system in general. And then we have all of, as we mentioned, all these gaps. So every individual, when pregnancy is started, through your insurance provider, MCO, through Medicaid, you would be assigned a perinatal health person to help connect the dots.
Well, that sounds amazing. And I think there's a lot more people that are going to want you to be their doctor after this. So, well, thank you all so much for joining us today. I want to thank Health Affairs again, and I want to thank the California Health Care Foundation, Perigee Fund, and WK Kellogg Foundation, as well as Zoma for very valuable insights, and also to Alan Weil of Health Affairs and Jennifer Moore, and to the entire Alliance team. Thank you so much for joining us. We will be sending a brief evaluation survey, and you can please make suggestions for future briefings on this or other topics that we will take a close look at. Please join us on November 9th for a briefing on advancing patient-centered cancer care, as well as on November 17th for a briefing on improving healthcare for people experiencing homelessness. And again, I want to thank Kay Matthews, Veronica Lisby-Bell, Carrie Hanlon, and Joy Burkhart for your time and energy and all of your work on these really important topics. Thanks again.